Today is the April 2019 MEC Minute. We're going to discuss important EMS articles that have been published in the past year or so. I'd like to shout out and recognize Dr. Slovis, the medical director for the city of Nashville. A lot of my discussion is based upon discussion he gave at the Eagles in March of this year. So shout out to Dr. Slovis. The first thing I'd like to talk about has to do with how we treat nausea and vomiting in the field, and this discussion is based upon an article that was published in Annals of Emergency Medicine last year regarding the use of inhaled rubbing alcohol or isopropyl alcohol for nausea control, and comparing that effectiveness to oral ondansetron or Zofran. And this was a study that was published about a year ago. It covered 120 subjects, and the protocol was broken into three arms. One arm of the protocol were patients who received just isopropyl alcohol. Essentially, they took a alcohol skin prep, opened up the package and placed it under the patient's nose and had them inhale through their nose. The second arm of the study had to do with patients receiving just oral Zofran or ondansetron. Then the third arm of the study was 40 patients who received both inhaled rubbing alcohol or isopropyl alcohol and oral ondansetron. And as part of the study, all subjects had both a oral dose of something, either a placebo or ondansetron, and had a swab under their nose that they inhaled. They didn't know that they're supposed to be smelling alcohol or not. So every patient as part of the study received both methods of treatment. Just some of the patients did not receive the alcohol and some did not receive the ondansetron. They used a visual scale in terms of rating the severity of the nausea, and they also looked at need for rescue antiemetic therapy. The big bottom line for this had to do with how much did the patient's nausea drop, or how much was it reduced by using these various methods. And if you look at isopropyl alcohol by itself, there was about a 32% reduction in nausea severity as rated by the patients using this scale. If you look at patients who received oral ondansetron, there's about a 9% reduction. And if you look at the patients who received both, there's about a 30% reduction. So the bottom line is really inhaled alcohol pad, isopropyl alcohol, works better than oral ondansetron, at least for us in the field, and that we should consider using it as our first-line treatment for patients who are complaining of nausea and vomiting. And we can use it quick and early in the course of our treatment, even before we get that IV started. So it's something to consider. It's cheap, it's easy, and I think the patients tolerate it well. Maybe also something they could use at home at another point in time if they have nausea, because most of us have some rubbing alcohol laying around the house somewhere. The next topic I'd like to talk about has to do with airways, and we're going to talk about two things. We're going to talk about apneic oxygenation, meaning providing oxygen therapy even if the patient's not breathing. And the second part has to do with whether or not we should be using cricoid pressure in the field to improve our visualization of the vocal cords as we intubate the patients. So the first article has to do with effectiveness of apneic oxygenation during intubation. In other words, the patient is not breathing either because they just don't have the respiratory drive or because we have chemically sedated and paralyzed them. And this was a meta-analysis of 8 studies and a total of 1,837 patients. So a meta-analysis means they took data from all 8 studies, pooled it into one database, and then did a statistical analysis. And it looked at the effectiveness of apneic oxygenation, meaning putting nasal cannulas in the patient's nose, turning the O2 flow rate as high as it'll go, so they're getting high flow oxygen via the nose as part of the intubation process. And this study showed that apneic oxygenation decreased the rate of hypoxia during intubation by 1/3. So it's something important to consider, and our take-home point is if you're going to intubate a patient, start them on high-flow oxygen via cannula. I think if you look at our RSI process, we're supposed to be hyperoxygenating these patients for several minutes before we sedate and paralyze. So get them on that high-flow oxygen, get it started, continue its administration during the intubation process. even if you're using a BVM. So you may need to actually have 2 oxygen sources for these patients so that the patient's on the O2 cannula receiving high flow oxygen during the intubation, and then you also can bag the patient with high flow oxygen, 100% oxygen. And then once the endotracheal tube is successfully in place, you can bag the patient and you can turn off the nasal cannula. But I think it's something very important for us to consider and make part of our routine practice in the field. The next item has to do with using Bougies and improving the likelihood of first pass endotracheal intubation. And this is a study that was done at Hennepin Medical Center in Minnesota. It involved 757 patients, and the study really had 2 arms to it. A portion of the population of the patients in the study had first intubation attempt utilizing a Bougie as the device that went through the cords first. The second had to do with, or the second arm had a patient who was intubated in our traditional way using a laryngoscope and a endotracheal tube with a stylet in it. And they used or did this with either the MEC blades or the Stort CMAC, which is a video device. A little over half of the patients were intubated utilizing the Macintosh blade, and the other patients were done via visual or using a video device. About a half of the patients had a difficult airway characteristics, which I'll define in a moment or two. So here's our best friend. This is the blue Bougie that we carry. I think I've mentioned it multiple times that when you're preparing to intubate a patient, you should think about what's your first method of choice going to be, but have that backup plan in place. For me, my backup plan is always to have the blue Bougie out and ready. I may not take it out of the wrapper, but it's out of the intubation kit, so it's ready for me to grab if I need it. So that's it. In terms of the study, they looked at all patients who were considered difficult versus the population as a whole, and those patients who were considered to have normal airways. For the purposes of this study, and I think we would agree that these types of patients are difficult airways, but the definition of difficult in this study had to do with any patient who had body fluids obstructing the view, so that could be vomit, it could be sputum, it could be other oral secretions, it could be blood from facial trauma, and so on. Or any patient who had airway obstruction or airway edema, so if you have a patient with an acute allergic reaction, or they had swelling of the tongue and lips from angioedema caused by a medication, or if the patient was obese, had a short neck, or a patient who may have a large tongue or a small mandible, or any patient with a cervical spine immobilization. I think over the years, I've had patients who not just have one of these criteria, but multiple criteria that make them a difficult airway. So they looked at these patients and they compared using the blue Bougie as the first device versus the endotracheal tube with a stylet in it. So what did the results show? So if you look at patients that were considered difficult using the Bougie versus a standard endotracheal tube with stylet, for the spinal patients who have spinal immobilization in place, their first pass success rate was 100% versus the endotracheal tube was 78%. For the patients who met their definition of obese, the Bougie was 96% success rate on first pass versus 75% for the standard laryngoscope or the laryngoscope video device, whatever, plus a tube with a stylet. And if you're looking at patients who have an incomplete view of the glottis, in other words, you can't see the entire architecture of the vocal cords, so you only see a partial view, the Bougie was 97% versus 60%. So the bottom line really has to do with using Bougies more. They are a key component of what we use as part of airway management. You should always have them available. If they're not on your intubation kit or your airway bag, please get them. They are an incredibly cheap device and they are very helpful. That little coude tip at the end, you get it past the cords, you can feel it click on the tracheal rings. If you can feel that click, you know you're in place, and then you can just guide the endotracheal tube over it. If you feel like you don't have enough experience using a Bougie, talk with your EMS coordinator. We can get you training time with a mannequin so you feel more comfortable. And then the other recommendation is start with a Bougie on difficult airways or go to one quickly after your first look. So if you have a patient who's got a anatomy issue or any other finding on exams such as spinal mobilization that would suggest a difficult intubation, have that Bougie out ready to go, and you could easily justify using it as your go-to device to get past the cords. Once the Bougie's in place, you just thread or feed that tube over the Bougie. So keep that in mind. If you don't feel comfortable using a Bougie, talk with your coordinator. We'll get you training time so you become more comfortable. We're also going to talk about airway. It has to do with cricoid pressure. I think we've all been taught that if you can't see the cords well, use thyroid or cricoid pressure. And this was a randomized double-blind study. They had actually almost 3,500 patients. Their first primary endpoint, in other words, their primary focus of the study was to determine whether or not cricoid pressure avoided aspiration. But they also had secondary endpoints having to do with how well could you see the larynx and how long did it take you to get the patient intubated. So the laryngeal view was important, and I'll show you a slide or two about that in a moment, as well as the percent of time where it took you more than 30 seconds to get that endotracheal tube in. So, for most of us, I think we're probably actually more interested in the secondary endpoints of the study than aspiration. But let's go to the aspiration and that primary endpoint. So if you look at the data where they used cricoid pressure versus no cricoid pressure, and again, this is out of a population of almost 3,500 patients who were intubated. Cricoid pressure, there's only about a 0.6% likelihood of aspiration versus 0.5% or a 0.5% event or occurrence of aspiration. And actually these data or these rates all are not statistically significant, but they suggest that maybe patients are less likely to aspirate if you don't put cricoid pressure. So the bottom line is, if you're doing cricoid pressure to avoid aspiration, it's probably not going to help you much. But I think the secondary endpoints, which I alluded to, which may be more important to us as clinicians, has to do with our ability to see the larynx and our ability to get the patient intubated. So when we talk about the view of the larynx as we intubate, there's this Cormack and Lehane grading scale, with a grade 1 being full view of the larynx. You can see the entire length and breadth of the vocal cords, and you can easily see where you need to put that tube. A grade 2 view is where you can see maybe the posterior elements of the cords and maybe the arytenoid cartilage, but you can't see all of the cords. So you have a good idea where to put the tube, but it's not perfect. A grade 3 view is you put the scope in and all you see is the epiglottis. You can't see anything past it. So you really don't know where you're going to need to go with your tube. You can kind of guess, but you have no idea. And then a grade 4 view is basically all you see is the back of the tongue. You see nothing in the hypopharynx. You have no idea where your tube's going to go. So if we're intubating a patient, ideally we want to see a grade 1. And if that's not adequate, most of us will gladly accept a grade 2. And when we get to a grade 3 and grade 4, to a large extent, we may be flying by the seat of our pants, hoping we get the tube in the right place. So how does cricoid pressure help us in terms of grade of view and endotracheal time to endotracheal intubation? So if you look at the viewing, if you look at the percentage of the time that we got a grade 3 or 4 view versus a 1 or 2, we actually seem to have done worse with cricoid pressure based on this study. So about 10% of the patients had a grade 3 or 4 view, meaning 90% of the patients had a favorable view. And if you did no cricoid pressure, you had about a 5% chance of getting a grade 3 or 4, meaning about 95% of the patients that you were intubating without cricoid pressure had a favorable view of the larynx, so you could pass your tube. So this study suggests that actually your viewing of the larynx with cricoid pressure is worse. If you look at endotracheal or time to successfully place an endotracheal tube, if you do a cricoid pressure, about 47% of the time it took you more than 30 seconds, whereas if you did not do cricoid pressure, about 40% of the time it took longer than 30 seconds. Meaning, again, cricoid pressure may have actually made it more difficult to get the patient intubated. In both of these criteria, whether it's intubation time or your adequacy of viewing of the larynx, the difference was statistically significant, meaning cricoid pressure is less likely to be helpful and is more likely to make your intubation attempt difficult. So the bottom line in terms of cricoid pressure, it doesn't decrease aspiration risk because those numbers are essentially unchanged, but it will make your intubation harder. So perhaps we should stop using the Selleck maneuver or cricoid pressure. So something to think about in your practice. Let's talk a little bit about nitroglycerin and rule out MI. So I think we've all been told that patients are at risk to drop their pressure if we give them nitrates, and should we use nitroglycerin in certain patient populations who are having chest pain or MI. And here's a study that was published, and the basic question is, how safe is nitroglycerin in patients with chest pain or who are having an acute myocardial infarction? This was a forward-looking study, so it was a prospective study. They knew from the beginning what their trial was going to be, and they were going to treat 780 patients suspected of having STEMI, elevation MI. This was in LA County and through UCLA. And it was a population of patients that may have an MI based on the ECG interpretation by the paramedic. And for this study, they allowed 3 doses of sublingual nitrates, and any patient who had a systolic blood pressure less than 100 was excluded from the study. So they were not going to give nitroglycerin to a patient who was already perceived as being hypotensive. So what do the results look like? So if you look at the percentage of patients who had a systolic blood pressure drop of more than 30 millimeters of mercury in this patient population, this occurred about 5.3% of the time with patients given nitroglycerin versus 6.7% of the time. This was not quite statistically significant, but essentially if you got no nitroglycerin in this population, in this study, you are actually more likely to drop your blood pressure versus if you did get nitroglycerin. If you're talking about pain control, if you're talking about a drop in the pain scale, 0 to 10, patients who got nitroglycerin had a net average change of 2.6% on that scale versus those who did not receive nitroglycerin had a change of about 1.4 just with EMS treatment. And this change is statistically significant. So what is the bottom line for us is nitroglycerin is safe as acute MI. Nitroglycerin is safe for inferior MI. Inferior MI was part of this study, and there was no statistical difference in terms of hypotensive response in inferior MIs versus anterior or lateral MIs. And then nitroglycerin does relieve pain in patients who are having anginal pain as part of their ACS or acute coronary syndrome. And for us, have respect, understand that nitro may drop pressure, but use it. I didn't put it into this portion of the lecture, but there was another study a couple years ago that specifically looked at use of nitroglycerin in patients with inferior MI versus others. And in that population, in that study, it showed that actually patients with inferior MI were less likely to drop their blood pressure with nitrates than patients who had an acute anterior MI. So I think what we've been taught in the past, that we should avoid nitroglycerin in patients with an acute inferior MI, I think that teaching has been shown to be a mistake. If you have a patient who has chest pain suggestive of an acute coronary event or has a STEMI on their 12 lead, and if their blood pressure is acceptable, use nitroglycerin. It's safe. But also be aware that it may drop their blood pressure, in which case you treat them with fluids or whatever you need to do to maintain an adequate perfusion. So again, nitro is safe, use it. Let's talk a little bit about use of intraosseous devices in patients who are receiving CPR. And this was a big study that came out of the Resuscitation Outcomes Consortium, which is a big consortium across the country, some big academic centers that do cardiac arrest research, and they look at the data and look at what procedures, what interventions seem to be therapeutic and to the patient's benefit. So in this case, they looked at, do intraosseous medications improve outcomes in out-of-hospital cardiac arrest. It was a total of 19,000+ patients suffering out-of-hospital cardiac arrest. About 3,000 of them had IOs placed. The others had IVs only. This study was only through the ROC EMS study sites, predominantly Dallas, Seattle, Kansas City, and Tucson. If you look at the population, the patients who received IOs tend to be younger and tend to be a little more likely to be female versus male. As part of this, they found that they were minimally faster in terms of getting medications in patients with an intraosseous device. Looking at this study, there was a lower rate of sustained return of spontaneous circulation in patients who had an IO placed. There was no difference in survival in patients who received IO versus IV, and that's survival to hospital discharge. And there was no difference in favorable neurological outcomes. So whether you got medications via an IO versus a medications via IV, there really was no statistical difference in terms of neurological outcomes or survival to hospital discharge. Sorry about that. There's been a couple phone calls coming through while I was trying to make this talk. So what's the bottom line? The bottom line is IO insertion is a great way to get IV access or intravascular access quickly, and that's true in a cardiac arrest, but use of an IO does not improve outcomes in out-of-hospital cardiac arrest. Now, I think as my own personal takeaway from this is the outcomes, there's no different. The IO is faster, but I think it's in line with what other research is showing, that really the only two things that make a difference in outcome for cardiac arrest has to do with use of high quality CPR as soon as possible and early defibrillation. I think it's been reasonably well shown that epinephrine and other intravenous medications generally don't make a difference in survival at hospital discharge. So if the medications don't make a difference, does it really matter how we give it to the patient, whether it's IV or IO? If the drug's not going to help, it's not going to help. Just a couple comments about double sequential defibrillation. We don't have it in our protocol. I know we've been asked several times if we're going to put it in the protocol. Hopefully by the end of this conversation you'll get my general opinion. I know Columbus continues to do it. But what is DSD, or double sequential defibrillation? That's where we actually use two devices to shock the patient rapidly, and it's not simultaneous, it's sequential, one shock then another. And we have defibrillator pads that are put on the traditional way at the left chest and as well as the right upper pectoral area, and then an anterior posterior pads are also attached. Generally we will defibrillate with these traditional pads, and then immediately after that firing of the defibrillator, the second defibrillator is fired, and the hope is that we'll get these patients out of persistent ventricular fibrillation. Most protocols allow anywhere from 3 to 5 standard defibrillations before going to double sequential. So here's a study that has to do with another system review and meta-analysis. Studies on this subject tend to be low volume, meaning there's not a whole lot of patients in each population that's studied or is part of the research report. But this was a review and meta-analysis, a total of 449 patients, and 95 of those patients were treated by double sequential defibrillation. They were all in a VF arrest, and they were all out of hospital cardiac arrest. So as part of this, they looked at a total of 2 retrospective trials and a total of 449 patients, with 95 getting DSD. I have to be aware that retrospective trials are not ideal. The preferred method of doing medical research is to do a prospective, forward-looking trial that identifies the interventions and the types of patients that are going to be in the trial. But anyway, if you look at this population, just under 60% of the patients were witnessed. That's a higher witness to rate than typically standard. And they looked at whether or not there was a return of spontaneous circulation, whether or not the patient was discharged from the hospital, and whether or not the patient was still alive 30 days after hospital discharge. So they looked at a large number of patients, and they had multiple outcomes that they were looking for. So when they did all this work, what did they come up with? Well, they concluded that double sequential defibrillation had no effects in survival to hospital discharge. There is no standard approach for when double sequential should be applied to a patient who remains in refractory VF. Again, it has to do with, do you do 3 standard shocks? Do you do 4? Do you do 5? So there's no consistency in terms of when do you use double sequential. And there was also, as part of their conclusions, concern that using DSD may lead to catastrophic defibrillator damage or failure, though this has not been described until about the time of the article coming out. I know we've heard from several of the defibrillator manufacturers that if you use DSD, it may void warranties and service contracts. If we're seriously considering this, then we probably ought to verify that before we go any further. I want to talk about a second study coming up that has to do with double sequential defibrillation. This was done in the San Antonio area. Just as a side item, one of the authors is Dave Miramontes. He is the San Antonio medical director. He's going to be at the Ohio Health EMS conference next month. He's a really dynamic speaker. He actually worked in Toledo before going to DC Fire and then to San Antonio. He's one of the authors. Dave's a good guy, so to me he gives a lot of credibility to the study. But the question really is double sequential more effective in refractory VFib? So they did a matched case control comparison. They had 205 patients with refractory VF. That's a large population of patients. For them, refractory was meaning they did 3 standard shocks with the defibrillator, and there was no resumption of ROSC. And they had 64 patients eventually received double sequential, and 64 received standard. The other patients were disqualified because they didn't have enough information on those patients. They had some observers involved, and the patients were pretty well matched. And if you look at the patients and how they were treated, the patients who received double sequential versus those who did not, they had similar doses of epinephrine, they had similar downtimes, they had similar rate of arrest being witnessed versus unwitnessed, and they had a similar rate of bystander CPR. So these 64 with and 64 without pretty much were well matched populations of patients. And what came out of it? Well, if you look at the data, those patients who had ROSC, only about 20% of those with DSD had ROSC versus those patients who had standard ongoing resuscitation, even though they were in refractory VF. About 40.8, 41% of patients had survival to discharge. If you're looking at survival to hospital discharge, then actually the patients who had standard defibrillation, standard treatment for refractory VF, had a higher survival rate at 23% versus 16%. So what was the conclusion of the authors of the study? So their conclusion was that their current protocol of use of DSD after the third conventional defibrillation in out-of-hospital cardiac arrest is ineffective. This is a well-done study, has a reasonably good number of patients in it, and the results of the study really went against using double sequential defibrillation in the field for refractory VF. So kind of in summary, looking at all the different articles, use high-flow nasal oxygen in patients who are being intubated, use Bougies frequently and liberally. I would consider using them as your device of first choice in those patients who you consider to be difficult or potentially difficult intubations. Cricoid pressure or Seldinger tick or cricoid pressure really is not effective, and it may actually make your intubation attempt worse. It does take time to become good at intubating patients and using those airway adjuncts like Bougie, so if you have an opportunity to practice, take it. Use nitroglycerin in those patients who have chest pain. Use nitroglycerin in patients who do not have hypotension but have STEMI. Use of IO in terms of cardiac arrest is questionable, and I think that has more to do with whether or not the drugs we use are actually effective rather than whether or not IO is better than IV to administer these drugs. There's no doubt that we can get an IO started very quickly. Double sequential defibrillation is not effective, and we should not be doing it. And then finally, the world of medicine keeps changing, and we need to adapt to it. So that's the end of my presentation. Thank you for your time, and again, thanks to Dr. Slovis for helping giving me some background to put this talk together. Thank you.